session of No Thrombosis Live. It's a national level workshop that we conduct every month based on stroke. And it's my pleasure to invite all our dedicated faculty members for today. So I'll start by introducing none other than Dr. Umar Karadan. Sir is an esteemed HOD and senior consultant neurologist at the Department of Neurology and Interventional Neurology at the Baby Memorial Hospital, Calicut. Sir is a pioneer in stroke care and neurointervention with extensive experience in 500 plus IV thrombolysis procedures, 100 plus mechanical thrombectomies, over 1,200 cerebral and spinal angiograms, and advanced neurovascular interventions. Sir is also an accomplished academician and educator. Sir is also an active clinical researcher and principal investigator in multiple national and international studies in stroke, Parkinson's disease, neurointervention, and neurocritical care. Sir is also recognized for his contribution during the 2018 Nipah outbreak in Kerala, receiving appreciation from the government of Kerala and leading medical organizations. Sir is also a passionate advocate for stroke awareness and
No, the
community
screen is
healthcare.
not shared.
I think it is already visible as you
No,
confirmed.
no.
Okay, just a minute. Yeah, is it visible now?
Yes, it's visible, but it's a Zoom screen.
Yes. Now?
Yes.
Yes. So, continuing, Sir is also passionate advocate for stroke awareness and community healthcare, leading numerous public awareness programs, telemedicine initiatives, neurological rehabilitation efforts, and charitable healthcare services across Kerala. We are very glad to have you on board, sir. Thank you so much for being a part of today's session.
Thank you. Thank you very much.
Moving ahead, we have Dr. Srijit Padikal. Sir is a moderator, senior consultant neurologist at the Aster MIMS Kannur. Sir has an extensive experience of over 9 years in acute inpatient neurology, neurocritical care, and epilepsy management. Sir leads the dedicated epilepsy clinic at Aster MIMS, providing a comprehensive care for adult and pediatric epilepsy patients. Sir has completed the prestigious epilepsy EEG and clinical neurophysiology course at Cleveland Clinic, Ohio, in the US, and secured the highest score in the program. Sir has an expertise in stroke, epilepsy, neurocritical care, the Guillain-Barré syndrome, myasthenia gravis, intracranial hemorrhage, vertigo, and neurootological disorders. Sir is also highly skilled in EEG, video EEG monitoring, nerve conducting studies, electromyography, evoked potentials, and the use of botulinum toxin therapy. He is also actively involved in academic activities, national and international epilepsy conferences, and clinical research. We are very glad to have you on board, sir, as a moderator for today's session. Moving next, we have our very first speaker, Dr. Jisa Merin Joy. Ma'am is a consultant neurologist at Baby Memorial Hospital with prior experience at KIMS Srishan Hospital, specializing in comprehensive neurological care and acute neurological emergencies. Ma'am has an expertise in acute stroke management, including intravenous thrombolysis, mechanical thrombectomy pathways, and management of stroke patients with the critical golden hour window. Ma'am has special interest in movement disorders with experience in patient selection and also post-operative programming for deep brain stimulations. Ma'am is experienced in advanced epilepsy care and is also skilled in neurocritical care, managing complex neurological emergencies. Ma'am also has an expertise in electrophysiology and neurodiagnostics, including the EEG interpretation, neuroimaging, neuromuscular disorders, to name a few. Ma'am is also recognized for academic excellence with awards at the Asia Pacific Stroke Congress 2021 and the NSI Travancore Midterm Meet 2022. We are so glad to have you as a speaker for today's program, ma'am. Thank you so much.
Thank you.
The next speaker for today is Dr. Karthik Harishankar. Sir is a consultant neurologist at the KIMS Srichan Hospital, Kannur. with advanced neurological training from PGIMer Chandigarh, one of India's premier medical institutes. Sir has a special interest and expertise in movement disorders, epilepsy, stroke, and neurorehabilitation, with experience in managing complex neurological disorders and advanced neurological care. Sir has completed his post DM senior residency with teaching experience at PGIMer Chandigarh and also served as a consultant neurologist at the MY Hospital in Mohali. Sir has been recognized as with the recipient of first rank and gold medal in MD General Medicine and awarded the Best Thesis Award by the Movement Disorder Society of India in 2024. Sir has also presented research at the International Congress of Parkinson's Disease and Movement Disorders and participated in the World Stroke Congress Abu Dhabi. Sir is an active member of the Indian Academy of Neurology, International Movement Disorder Society, and also the World Stroke Organization with publications and book chapters in movement disorders, stroke, and neuro-ophthalmology. We are so glad to have you on board, sir, and also thanks to all the faculty members once again. With this, I would like to hand over the session to Dr. Umar. Thank you so much.
Thank you. Thank you very much. And uh, much pleasure to have all my friends, Dr. Srijit, Dr. Jisa, and Dr. Karthik with me. And I think I would just start the ball rolling, followed by my friend, Dr. Srijit, will be taking over, and followed by Dr. Jisa and Karthik. I'm sure that until 1995, we had only aspirin. Nothing else was there. Then there's a trial, the NIN's trial, the NINS trial, which introduced the new molecule actylase for the first time. Initially, when I used this molecule in 1999, when I just passed out, I'm in early 2000. I was not sure because I was really skeptical about the use of this molecule. Then then we had a patient with a hemiplegia and aphasia, and we started this medicine for the first time in a baby memorial hospital. And to our dismay, we found that it really worked. He totally recovered to normalcy without any sequelae at all. That is the first time when I got experience with this small molecule for the first time. And since then, I knew that this molecule is going to stay, and it is staying. And in fact, we had thrombolysis even 3 to 5 cases per day also, so at some point of time. So then came the intra-arterial thrombolysis, the PROACT 1 and PROACT 2 trial, which showed the intra-arterial thrombolysis as good as this. It's with a 60% rate annualization. Then there is a time of a doom. Then people were doing the neurointerventional procedures, and in 2013, it was found that it's not, the neurointervention mechanical thrombectomy was not at all effective by various studies, since synthesis and IIMS3 and all. And the New England Journal put a last nail on the coffin that is not effective. Then in 2015, there 5 trials came: the MR Clean, Escape trial, Revascat, Thesis, Trace, and Swift Prime. Everyone showed that mechanical thrombectomy is excellent with the number you treat is only 2.46. It is a very effective molecule. Then recently, the Select 2 trial showed that even high core thrombectomy with an aspect score of 2 to 5 still is effective, and this trial has to be stopped because it was found to be effective. And now we can even mechanically do mechanical thrombectomy up to 24 hours or more. In fact, I had done more than in 31 hours also with a very good functional recovery. Now we know that even with the large core, the functional benefit at 3 months are much better compared to medical arm. Then there's a time that the ICAS-3 proved that it can be used. The IV thrombolysis can be used up to 4.5 hours. Now that there are multiple studies, the tenacity study is on the way. It is the purposing is that it can be used beyond 4.5 hours. The study schedule can be used up to 72 hours. Is on the way. Probably in 1 or 2 years, we would get an answer whether this thrombolytic molecule can be used beyond the scheduled 4.5 hours, 9 hours, 12 hours, 24 hours like that. So I think we are going to have a very interesting session and talk by my colleagues. And without much ado, I give the mic to my colleague, Dr. Srijit. Over to Srijit, please.
Thank you very much, Umar sir. Am I audible?
Yes, sir.
Yeah, thank you very much. It's a pleasure and an honor to participate in a session being chaired by Umar sir, because he's a pioneer in stroke intervention. He's a practicing, very busy neurologist, but he finds time to do neurointervention very actively, and also he engages in teaching stroke to all of us, including myself. And Karthik and Jisa are my friends and colleagues. So I think without much delay, we'll go into the cases, and I presume that they have chosen some interesting cases. So let's see the case, and then we'll listen from them what were the challenges they were facing in making a decision, because each stroke case is unique and it cannot be easily decided by the boundaries defined by our guidelines. So after, and at that point, we may discuss the potential options, and then we'll get the final opinion from Umar sir, and then we'll proceed and we'll see what happened to that patient. Is that fine, Karthik and Jisa?
Yes, sir.
Yes, we'll proceed. Okay,
Yes.
Karthik, are you presenting first or Jisa? Jisa.
Okay,
Anyways,
yes,
it's okay, sir.
Yeah.
Okay.
So shall I start, or ma'am would like to go first?
Jisa,
Whichever
you
is
choose.
fine. Yeah.
Jisa, you
Actually,
start. Jisa, start. Jisa, you start.
Senior
Okay.
can decide.
Okay.
Okay, sir. Thank you, sir.
You
So
say
am I
you're not?
audible?
No, you're
Yeah,
audible.
you are audible.
Yeah, okay, thank you. So, good evening, and I'm happy that I've got an opportunity to present a case over here, and thanks a lot for that. So, coming directly into my topic, it's a case of a recurrent stroke. A 50-year-old male with no addictions, he came to our casualty with a history of altered sensorium with gait instability for the past 1 week. And his wife gives history of migraine, and she presented like he had recurrent episodes of headache with a photophonophobia, and he prefers to lie down in a dark room whenever he had this headache episodes. And some of these episodes are associated with vomiting, and some of the episodes alleviates with vomiting also. And he had these recurrent episodes for the past 15 years. They've been married for past 20 years, so she knows the history from for the past 20 years only. And he developed seizures with the semiology of GTCS. In the first episode of the seizures was about 10 years back. He was non-compliant to medication, so he was developing recurrent episodes of the same for the past 10 years. Then he developed a systemic hypertension 8 years back, and for which also he was non-compliant and he was not taking medications properly. And he developed a right gangliocapsular bleed with a residual left hemiparesis in 2023, after which 1 or 2 weeks after the treatment, he discarded all the medications, and he was not on any treatment at that time. And then he developed recurrent right MCTIA. That means he had multiple episodes of increased left hemiparesis in 2023, 24, and 25. And then he developed a ischemic stroke with the increase in the residual left hemiparesis, and he had a right pontine infarct at that time. And he was admitted in a local hospital for about 5 days. And after that, he was discharged. He was apparently fine for the next 4 to 5 days. Then he developed a gait instability. He was swaying to both sides while walking, and then he developed altered sensorium. He was evaluated in a local hospital, and he was referred here to our hospital for further management. So according to his wife, his pre-morbid condition was he was a short-tempered person by nature. And his aggressiveness has increased for the past 5 years with a recent memory impairment. That particular person was a manual laborer, so he used to forget where his things are, where his tools are kept, and all. And he repeats himself for the past 1 year. And he makes calculation errors while he gets his daily fee and all. And he developed emotional lability. At first, he was very aggressive. Later, he started crying. He started having crying episodes also. Even though all these things and all with all these deficits, he could carry out his daily activities till 1 month before the admission. So on
Uh,
examination, he had, yeah,
Sorry,
sir.
Jita, I just want
Yes,
in
sir.
because just for the discussion. So, from the history, what is your differential diagnosis?
Sir, he has recurrent episodes of stroke, sir.
Yeah.
With the history of migraine, with the
Yeah.
history of long-term seizures, systemic hypertension. So we can think of hypertensive arteriosclerosis, one thing, ICAD, then migraine, seizure, cognitive impairment. We can think of CADASIL also.
Yeah, vasculitis or even a
Yes,
moya also.
yes, sir.
Okay.
Also, yes, sir.
Sir, can I interrupt?
Yeah, sure.
This case is very interesting because it is not the way a typical garden variety of stroke presents. So we got a few things in the past, like with an older adult male patient with history of migraine, then seizure disorder, probably predating the vascular events, and you got a bleed that is located deep in the basal ganglia bleed, then ischemic strokes. So one thing, and also this behavioral changes. So it is actually involving the multiple areas of the neuroaxis with bleeds and ischemic strokes and preceding migraine. So one thing that's of interest is there a MRI available which is done for the evaluation of seizure, like somewhere 5 years or 8 years before, that would help us to narrow down some of the differential diagnosis. You may not discuss it here, but
Yeah.
that is if that is available, it will help us a lot, I think.
Yeah, sure. All right. Please go on.
Sir, I could get all the history from the wife only, and some of the past history from the prior hospitals. None of the imaging was available.
Okay, thank you. Thank you.
Okay, sir. Then coming to the examination, he had a tachycardia with a BP of 210/170. He was afebrile, and he had a respiratory rate of 26 per minute with an SpO2 of 93% in room air. The patient was drowsy and irritable. He was minimally opening eyes to calls. He was occasionally obeying simple oral commands. He was almost always irritable at the time of admission. So we couldn't make much from his clinical examination. Only thing that he had a left upper limb and lower limb positive movements. That's the only thing that we could make out during the first examination. By the next day, we could find out that he had bilateral element facial palsy. And coming on the third day, and at that time, we could make out that the patient was having some kind of gaze abnormalities, but what it was could never be found out on the second day because he was not responding to our queries, and he was very his attention was quite impaired, and he was very aggressive also at that time. So the next third day, when he became much better, his sensorium improved, we found out that he had webinar. So he had a bilateral element facial palsy. He had a webinar, and on that day we could do gag reflex also, and it was brisk. On that day, I could do some examination over the patient, and he had all four limb. He had spasticity. Right upper limb and lower limb, he had a positive movements. It was only 2/5. Left upper limb and lower limb, it was 4/5 with a brisk DTR. On the third day, when he was made to sit up, he had a truncal pulsion to the right also. And his sensory was unreliable almost all the time. Throughout the course in the hospital, his attention was impaired. So cognitive testing was could not be properly done at that time. He didn't have any neck stiffness. Skull and spine was normal. His RS showed bilateral basal capitations more on the right intrascapular area. And during the course in the hospital, on the day prior to his discharge, I could see his fundus. and it had a flame hemorrhages also bilaterally. And during the course in the hospital, he started crying also. At first, he was aggressive. Later, he developed emotional lability. Sir, shall I move to the MRI brain, sir?
So basically, there's a brainstem lesion in the Ponday lesion.
Yes, sir.
Bilateral Ponday
It's a
lesion.
posterior circulation. Yes, sir.
And he has got a cognitive involvement, pseudobulbar effect, and
Yes,
frontal, bifrontal, as well as temporal dysfunction. And probably the left-sided weakness could be because the old bleed. And the present one with the dominant feature would be on the left side. Probably that's the reason he has got a predominantly right-side weakness. So the probably is a left pondine, which may be crossing to the opposite side, given rise to bilateral element, mainly more posterior in the segment with the bilateral intraocular ophthalmoplegia. Okay.
Okay. So the MRI brain taken showed a large acute impact in the left cerebellar hemisphere, right cerebellar hemisphere, and left hemipoles. So we were at loss, like what was the cause of the webinar? It was only left hemipoles. But his history was like he had a right pontine impact also. So he might have been having INO at that time. So it must have been culminated when he had a left hemipontine impact also. It must have been culminated in webinar. That's what we thought of. This is a
Jisa,
yes, sir.
can you show the diffusion, because it may take some time to grasp the thing. So can you show the diffusion, then
Yes, sure.
show the flare to see the burden of small vessel changes, then we'll see the SWA or gradient, then
Okay,
the
sir.
vessel imaging. That would be the better way.
Yes, sir. Sir, this is fine, sir.
Yeah.
It's okay, right, sir?
Yeah, it's okay.
Next comes the T1, sir.
Okay.
That's ADC, sir. It's the rotative flare, sir. So you can see that the basal ganglia is being involved, but the external capsule is spared. And the anterior temporal lobe is also not that much affected, as you can see that in CADASIL.
Okay. So you are thinking of CADASIL, but that hallmark features were not there, but small vessel disease is prominently there.
Yes, sir. The history was actually directing us to a CADASIL or either to a CAA, but CADASIL was more likely. That's what I thought. But here the external capsule is not being involved, and the anterior temporal lobe is not also that much involved.
This looks like a deep watershed, so watershed also, especially on the left side. It's a bilateral deep watershed.
Yes, sir.
And here mainly there's a pondal leukoarea, pondal infarcts, as well as bilateral small basal ganglion thalamic lesions infarcts are there.
Okay.
So
and the
small vessel, ponds also grossly affected.
For the pondine acute lesion localization, Umar sir was spot on with predominantly left side involvement and more tegmental involvement. Great, sir.
And because the contrapulsion towards the right side. So the gravis septic pathway is affected on the ponds.
And there was multiple microhemorrhages in the bilateral cerebellar hemisphere and the brainstem.
And the distribution of the microbleeds were more deep or more superficial? I just want to see that once. It's a lot of things are there in the cortex also, right?
Yes, sir. Yes, sir.
The cortex as well as basically in the deep
Deep area, sir.
areas, which cannot, yeah.
Deep.
Would you go down to this cerebellum once again? I just want to see the folio of this cerebellum.
Volumes.
Because there are some, black, blue blooming is there, much more blooming there.
Yes, sir. Then there was a complete occlusion, near complete occlusion of the left vertebral artery and basilar artery also. He presented beyond the winter period. So after 1 week only we saw the patient. After 1 week of development of the symptoms only we saw the patient. There was no role for thrombectomy at that time. And what we have given to the patient is only antiplatelets and statins. The routine treatment that we have given. The patient was completely bedbound, on Ryle's tube, on Polish catheter at the time of admission. And by seeing all this bilateral facial palsy and webinar, we thought of even Lyme's disease. So we have taken an MRI brain with a contrast 2 days after we have taken the MRI brain. There was no leptomeningeal enhancement. And to our surprise, there was a recanalization in the vertebral artery and the basilar artery. We haven't done anything. We have just given the dual antiplatelets and hydrostatins. And there was no hemorrhagic transformation. So we, even though microbleeds were there, we were in confusion whether to think of CAA.
CA usually mainly cortical, more this is basal ganglia, everything. So CA is this age and things, and unlikely high blood pressure, and the more deep stress structures getting affected.
Okay, sir.
And this could be some ICAD, maybe some intracranial atherosclerotic vascular disease. Is involved in the MCA as well as the vertebrobasilar system, probably contributed by some hypertensive disease or a vasculitic or a large artery, so large and small artery disorders, something like that. Okay.
Okay, sir.
No family, right? No family history.
No, sir. No family history.
So can we imagine this as case two mechanisms of stroke operating with a small vessel disease probably causing the previous basal ganglia bleed as well as the burden of deep small vessel changes and the microbleeds. There is a prominent small vessel disease as well as ICAD in the form of basilar artery occlusion. Am I right, sir?
Yeah, sure. Yeah.
Both the mechanisms are operating properly.
So undetermined cause, stroke due to
yes. So two competing mechanisms, so we'll go into undetermined. Yeah. So is there any chance that it could be embolic? It's less likely, right?
Yeah, it can still be, because artery to artery embolus also we have to think. Because
yes. Cardioembolus, I was asking. Yeah, it's less likely.
Because
still you need to work up, no?
Yeah, we have to be, especially as a good recanalization means it could be a soft thrombus, maybe from the heart. It's gets stuck in the vertebral artery and the basilar artery getting dissolved. The other possibility would be a V3, V4 dissection or some atherosclerotic changes, which must have clotted, thrombosed and later recanalized. Because he has a bilateral cerebellar infarct indicating a proximal, a V3, V4 vertebral artery on both sides. Because we cannot explain by a basilar occlusion. So there must be bilateral distal V3, V4 vertebral artery. It can be proximal also, but the location of it's in the dispersion pica. And there is infarct in the pons perforatus because the pons is getting affected along with the MCA branches. the lenticulostriate branches or the deep territories. Yeah, please go on.
So the DTs we have considered at that time were hypertensive arteriosclerosis, CAA, Lyme's disease, and CATASIL. So we have done whatever we could, all the investigation that we could, and the patient was from a poor background, so they couldn't do much of the investigations. Even though GBS is not a DD in this particular area, seeing the bilateral element facial palsy, we have even thought of that, but it's not actually possible with an underlying brisk gag reflex also. Anyways, there was no albuminocytological dissociation. The TB PCR was negative. That is the only investigation that has been done in CSF because of the patient's financial constraints. CBC was fairly normal. Only the HB was 12.7. ESR was 33. CRP was 19.6 at the time of admission, but there was a serial reduction thereafter. Procalcitonin was negative. RF factor, and we have done all the vasculitic workup. RF factor, CNCA, PNCA, ANA, IF was negative. The urine routine, LFT and RFT was fairly normal. The urine routine was also normal. The peripheral smear showed normocytic normochromic with a neutrophilic leukocytosis. HbA1c was 7.4, here detected as a newly detected diabetes mellitus. And IgM, IgG, we have done that, and it came to be negative. NOS3 gene mutation was also not detected. We have done an echo which showed only concentric LVH. The 24-hour Holter did not reveal any evidence of atrial fibrillation. We have done USG abdomen and pelvis to rule out any renal manifestation of the CADASIL, and we could get only grade 1 fatty liver. So this is the Lyme's. Yes, sir.
What about the HIV and VDRL?
We haven't done the serology, sir. They were actually not keen on doing the serology, sir. HIV, we have advised them, but they were not keen on that.
Mm-hmm. Yeah. And the MRA contrast MRA is done. MRA
Yes,
angio.
sir.
Okay.
Yes,
Okay.
this one, sir.
That's it.
That's the only thing I could get, sir.
Okay. Okay. All
There
right,
is a sagittal section also which I couldn't copy.
Okay. Fine.
So the final diagnosis, CAA was not a satisfactory diagnosis for us, but ultimately I wrote in my final in my discharge sheet as possible CAA and hypertensive arteriosclerosis, bar hypertensive arteriosclerosis with an acute ischemic stroke with bifacial palsy, Webinar, and hemiplegia and truncal pulsion, in fact involving both the cerebellum and the pons, the posterior circulation stroke, with a recurrent stroke and recurrent right MCA or old right GC bleed also. He never had any subarachnoid hemorrhage or a lobar bleed from the history. And he had probable vascular dementia with a pseudobulbar effect, seizure disorder, hypertensive emergency. And this was the diagnosis that I have given in my discharge sheet. Unfortunately, I have taken the video of the webinar, but I lost it. And this is how actually the patient himself has sent this to me yesterday. Eric, he's still in my follow-up. When we discharged the patient, he was completely bedbound on Ryle's tube and was on Foley's catheter. Now he could walk like this, but he is developing a recurrent aspiration pneumonitis. Even now, even after 1 year. So I've seen this patient in March 2025.
That is a remarkable recovery, right?
Yes,
Yeah.
even
That's-
I was quite astonished, sir. I didn't do anything. I just gave him dual antiplatelets. I controlled his BP. That's the only thing that I have done.
Yeah. Yeah, that is the best thing to do because double antiplatelets for 3 weeks followed by statin and modification of risk factors. I think this case you have to do a angiogram. 6
Yes, sir.
because he has got a vascular disease, he has got deep watershed, he has got watershed infarction. So probably say ICA may be affected. That's reason he is getting a deep watershed, watershed as well as bilateral vertebrobasilar symptom. So ICAD is
Yes,
one strong possibility in this case.
yes, sir.
We have to do VDRL also, simple thing like VDRL.
Yes, sir. BP adjust. Yes.
Anyway, it's a very, very nice case. And CA is very unlikely because there is no cortical bleed, no lobar bleed. and his high blood pressure and the age group. See, it seems that is still a vascular dementia due to multiple cortical and subcortical and brainstem infarcts.
Okay, sir.
What do you think, Srijit?
Perfect, sir. So I was thinking like this, like only odd point in this case is his some of the seizures and the other manifest behavioral symptoms were predating the clear-cut vascular events. So
Yeah.
that is the
Yeah.
usually get a post-stroke epilepsy after the stroke, not like a covert stroke producing a. It can happen, but still,
Yeah.
he got epilepsy much years predating the vascular events. So I was thinking like in the etiology framework, ICAD, small vessel disease, and like sir mentioned, non-occlusive ICAD involving the anterior circulation as well, producing some involvement which might have been missed in the MR angiography using the TOF. So by doing this proper angiogram, DSA, like sir told, we will find out a like non-stenotic atherosclerotic burden, and probably that may be contributing to the present. Alternatively, it may be two mechanisms operating, one being a small vessel disease,
Maybe
and along with ICAD.
Yeah,
Okay,
and yeah, that's true. Absolutely true. And but I feel that the seizure may be due to high blood pressure, accelerated hypertension, give
Yes.
a press-like mechanism can also work.
Yes, sir. But that has been there for some years, sir.
Yeah, no, 170 is actually is 170.
Yes,
So,
sir.
yes, sir.
So similarly, like ICAD patients are also prone to get this renal vascular disease. So there may be a renal artery stenosis as well in this patient because he has got very high BPs and all.
So yeah, this case I think we should work for this secondary cause of hypertension, renal artery stenosis, hyperaldosteronism, and renal workup and all the other workup, and along with angio, including renal angio.
Okay, sir. Sure, sir. Okay.
Any question from the audience or some?
No, so currently there are no questions. The audience has joined through a separate link. This is just the faculty link, and there are no questions in there currently.
Yeah, sure. Then I think, Srijit, then can we go to the next case then?
Yes, thank you, Jitha, for the excellent presentation, and you
Very
discussed
nice.
it very well.
Very nice.
Thank you. Thank you, sir.
Sir, can we proceed to Dr. Karthik presentation?
Sure, please.
Sure. Karthik, please.
Am I audible?
Yes.
Thank you for this wonderful opportunity to present my case in front of giants of neurology. So mine is a very small case, a case which sort of made me think differently. So so I have actually two cases which actually came with the relatively same presentation. So the first case is a 69-year-old female. She actually presented with diplopia and blurring of vision, which she noticed after waking up suddenly at around 3:30. Then she came very late into the hospital. So she came. She presented to the hospital at around 3:30. At presentation, her blood pressure was high. It was 180 by 100 with a pulse rate of 100. The power was 5 by 5 in all four limbs. The sensory and exam was within normal limits. There was no cerebellar signs. So these were documented from another hospital. So initial documentation was like there was right hypertropia, vertical diplopia in all directions, more on the left lower gaze. There is no history of ptosis, fatigability, vulvar symptoms, or respiratory difficulty or headache. So in past, she had one history of CVA, an old left basal ganglion infarct in 2023, for which improved to MRS1. She is a diabetic, hypertension with osteoarthritis, diabetic for the past 10 years and hypertensive for the past 5 years. She attained menopause at 50 and last childbirth was 25 years back. So the initial MRI, which when she came, it showed actually a right subacute kind of a subacute infarct in the right corona radiata. There were grade 1 microangiopathic changes along with a chronic infarct in the left gangliocapsular region. The MRA did not show any major vessel occlusion or significant stenosis, and there was also a hypoplastic right fetal PCA. So with this, which was not correlating to the vertical diplopia, there was actually nothing significant noted in the initial MRI in the brainstem. So subsequently, she underwent. Yes, sir. So you're not audible, sir.
Yeah. Well, what's your clinical diagnosis in this case?
So at this point, it is like an acute onset presentation, but the MRI did not show a lesion which is corresponding to the clinical presentation.
So clinically, he has a midbrain lesion, probably right side, right?
It could be a right trochlear nerve lesion or a left trochlear nucleus involvement. Clinically, that is a possibility, but unfortunately, the MRI was not showing any such finding.
Those cases, I think we should have a thin cuts, both coronal and sag.
Yes,
only,
sir.
Then otherwise, it's very likely to miss in this case.
Yes, sir. Yes, sir. That is
my. Yeah, one is in the brainstem, one is high up in the corona. But yeah.
Oh, yes.
Please.
Yes, sir. So she was evaluated subsequently. Her echo was normal. The HbA1c was 7.8%. It was like there was high blood sugars. She was already on aspirin. So initially, when she came to the emergency, based on the infarct, she was loaded with aspirin 150, clopidogrel 300, etoposide 80. The rest of her investigations were within normal limits. So the further investigations, because there was no, she was evaluated further. The MRI was actually repeated again, but there was nothing new in the repeat MRI. The optal exam consultation also noticed, they also just documented a diplopia, which is in all directions of gaze, with nothing specific. The RNS also was done, considering the MRI to be normal, and RNS was also done, which was also normal. The MRI with contrast was done subsequently. In that, like after 3 days, when the MRI with contrast was done, there was some doubtful diffusion restriction in the pons in the right paramedian location with no corresponding changes in ADC-T2. Query artifactual was the report, but she was, I will show that image. This is that image of that small lesion. It looks, this is actually in the lower end of pons. It is more clear in the sagittal section. So there is a small lesion in the with flare changes in the lower end of pons. And
it is true only. It is true infarct only.
Sir?
It is infarct only.
Yes, sir. Yes, sir. It is a small infarct. So, but the question is, can a vertical question which stumped is, can a vertical diplopia be presented by a pontine infarct? So actually, midbrain is the usual localization, but even a pontine lesion can present with a according to literature, it can present with vertical diplopia because the input from the vestibulo-ocular pathways can go through the MLF and reach the ocular motor in the midbrain. So any problem in the pontine region also can cause a vertical diplopia, which is sometimes called as a pseudo fourth nerve palsy. So this could have been one reason why she developed a vertical diplopia. Anyways, she was treated.
Sorry. So I think because it feels that there's a skew. He has got one eye up and one eye down. Okay. And you are seeing that there is because probably the graves the ascending graves septic pathway is affected. Probably he has got a one eye up. That means either that depressor is down, this thing, or the elevator is weak. So probably in this context, the diplopia is worse on looking down onto the left side. I mean, one possible could be a fourth nerve or one on the right side. But in this case, probably there's a skew, vertical skew, because of the pontine relief.
Yes, sir. So
can I Karthik, can I interrupt?
Yes, sir. Yes, sir, please.
Like we will think about stroke, etiology of stroke because of the clinical presentation, acute presentation. So rather than saying that it is an acute presentation of a trochlear nerve, rather than we think of trochlear nucleus or the fascicle of the trochlear nerve, no, in the brainstem, rather than a nerve pathology which may present rather more subacutely rather than this acutely. So we consider stroke based on the clinical presentation. And we got only a supratentorial infarct, not something which we look for when we see such a finding. So, like we learn in Hints test, up to 85% of posterior circulation will only show up in the initial MRI. Up to 15% will be negative. That is why this Hints is being proposed as a very useful test because of this 15% missing in the initial. So the MRI people will take a coronal cut or change the B value for the diffusion and will repeat a MRI at 24 to 48 hours to increase the sensitivity. Still, we may miss some lesion. So sometimes what we do is that when we get a stroke presentation and when we get a supratentorial infarct, sometimes we take it as a supportive evidence for a missing infarct in the brain, small infarct in the brainstem, and which is proved in your case at the third day MRI. And just to note that last week, Madhu sir's case discussion, he was talking about this para-MLF pathway ascending from pons to midbrain to account for this this vertical diplopia due to a lesion like in your case. Sir must be remembering. So it is just interesting. Just last week, he was discussing about the same para-MLF pathway resulting in vertical diplopia due to a pontine lesion. Umar sir, do you remember that discussion?
Yeah.
Yes.
And these cases, unless you do a very thin cuts, you are very likely to miss because these are very small infarct. And those cases, you have to specifically tell the radiology that there's a brainstem infarct. So we have to have a thin cuts and probably the multiple in this, not only in the axis, but in the sag and the coronal.
Coronal is very useful in this case somehow because that will pick up and that is much more convincing whether it is an artifactual or something. Coronal is very useful.
Yeah.
Okay.
So she was the story is still not over, sir. So actually, she was this was a discharge diagnosis. She was started on and double antiplatelets and discharged after 5 days. There was no worsening, and she was continued on a previous OHA and she was discharged. So 1 week later, on 14th of the next month, she developed sudden onset facial deviation to the left with an inability to close the right eye. And there, she also said there is a mild worsening of my diplopia. She came back to the hospital again. So she was general condition was well preserved with no meningeal signs. The blood pressure was still high at presentation. The extraocular movements were actually this time it seemed to be normal, but there was a right element facial palsy with a doubtful ptosis also. But the power was normal. There was no cerebellar signs. Again, the MRI was repeated. This time, it showed that previous MRI changes with no new findings with clear sinuses. So because of this presentation of multiple lesions, he actually was suggested for a CSF analysis also. But somehow she was unwilling, and the possibility of a multiple cranial nerve palsy was considered. And she actually, this is how she presented to us. So when she came to us, her blood pressure was actually high. On examination, there was facial deviation to the left with loss of nasolabial fold in the right. Extraocular movements were normal. There was some mild diplopia, which we are not able to characterize. There was no history of pain behind the ears or any vesicles during this presentation. The investigation showed a lipid profile, showed an LDL of 77. So when she came...
Yes, sir. Karthik, can you explain with the stroke alone? Where do you want to bring another etiology? Because since you have found multiple infarct, one in the supratentorial, one in infratentorial. It can be another infarct involving the nucleus, an element nucleus, the seventh nucleus in the pons itself.
Yes, sir. But the thing is, the MRI did not show it. That is one thing.
Yeah, because this MRI, the usual MRI won't pick all these things unless you specifically ask for. Because I had multiple cases, we published also. There's a small infarct, so small bleed in the nucleus, the seventh nucleus, and one patient had a demyelination involved the seventh nucleus, and another had a bleed in the seventh nucleus. Multiple case reports are there. Small, very less than a millimeter, sub millimeter infarct involved this seventh nucleus. Give us to LLMN.
If I remember correctly, sir has presented a case of Bell's-like case with nuclear stroke in World Federation of Neurology, I think, in Japan. Yes.
Okay, sir. Being a junior consultant, I was like a bit stumped that the MRA is normal. So we actually.
No, Karthik, that is very pertinent because I have burned my fingers with stroke-like presentation with posterior fossa, brainstem, cerebellar mass lesions can present just like stroke, and then they evolve. Then sometimes a small area of diffusion may be there, but the case may be a myasthenia gravis. These two have happened to me myself, not in the literature, but I've seen such cases. So your concerns are very pertinent. Okay, please.
So basically, sir, because she had presented with a recurrent infarct in spite of double antiplatelets, we changed the antiplatelet to ticagrelor 90 mg BD. Then we did a 3-day Holter, which was actually came to be normal. The ESR CFP was normal. I thought we should evaluate further why she's having these recurrent strokes. So we did a USG which was showing some myometrial calcification and some fluid in the endometrial cavity. The D dimer was normal. So I was thinking, is there any other etiology which is leading to these multiple small strokes? That was what I thought. I sent it because she's an elderly lady. I sent the tumor markers which all came normal. The X-ray was normal. We did a vasculitic workup also, and viral markers. Everything came normal. And other than this visit, she did not have anything. So after 2 days, we actually repeated the MRI again. And actually, exactly as you have told, there is a small infarct sitting in the pontine region involving the right facial nerve nucleus. So probably this was missed in that first MRI, and that is the reason for this presentation, as you had pointed out. So I also searched the literature. So pontine stroke presenting as isolated facial palsy is a very recognized entity. So in that cases, I think we should our clinical suspicion should be very high. That's what I sort of learned. Sir.
Yeah.
So these are usually these are usually due to infarcts involving the basilar artery perforators and other small vessels in the posterior circulation. So because of this thing we got in the MRI, we optimized her vascular risk factor even further. We advised for intensive glycemic control with insulin, intensive blood pressure control, high intensity statin with a target LDL less than 50, and ticagrelor. So I'm still a little confused whether is my diagnosis complete or is there anything underlying which is still burning. So I'm keeping her under very close follow-up. I called her after 2 weeks. She's fine. And they were also very exhausted by these recurrent hospital visits and the prolonged stays. So we advised for a close follow-up. After 2 weeks, she's stable. 1 month, 2-month follow-up, she's actually quite stable. So she's doing well. So I just reviewed the literature of recurrent lacunar infarction following previous lacunar stroke. So it is quite common to develop these multiple lacunar infarcts. Main risk factor, which the study was done on 122 patients who developed a recurrent lacunar infarctions, and the main risk factor they have identified is hypertension, and multiple vascular risk factors can always lead to a recurrent lacunar stroke. Another thing which I sort of thought in this case was clopidogrel resistance. So it is estimated that 50% of the South Asian population having clopidogrel resistance according to some studies, and it has other drug interactions with omeprazole and other drugs, and even diabetes has been found to be a bit of a risk for clopidogrel resistance. She was a diabetic, and also alternate pathways are also considered a risk for clopidogrel resistance. So we upgraded the antiplatelet.
You are not audible.
Not audible.
It's audible, sir. I can actually hear.
Okay. So should I repeat, sir?
Yeah, sure. No, it's okay. Yes.
Okay. So these were my thoughts when I saw this patient, sir. I had to just show another small patient. This is a very small case.
Just a moment. The so-called clopidogrel resistance, though it is found, it is not absolutely true because I mean, though it is highlighted that this 30%, 40%, in practical sense, it doesn't happen. And most of the time, aspirin is as good because after 3 weeks, you have to have either aspirin or clopidogrel or ticagrelor. And personally, I don't use ticagrelor except maybe very, very rare case. Even for after stenting, we don't use ticagrelor for carotid stenting. And I think it's better to do a transcranial Doppler also for hits. Just see whether a small emboli is going from the heart. So just a bubble test and look for that.
Bubble test. Okay,
Yeah.
sir. Sir, but can PFO present this late? Is it heard? Or?
PFO can, because PFO, it can, it can cause small artery, large artery, things like that. So it's a microemboli, So it can still
I've not done that, sir. In her follow-up, I'll try to get that done.
Yeah, it should be done. I think it's one of the tools that we should make use of.
Okay. So I have a very similar case. Another
Hey,
case.
Karthik, one or two comments from my
Yes,
side.
sir.
One thing is, you told that MRI missed the initial. It's not actually missing. Like that is when saying that the radiologist didn't find it out. Sometimes these strokes will not show up in the MRI, even if you do with very thin cuts in the first 24 to 48 hours. Somehow it become evident only on the follow-up imaging.
Yes,
20% can still be missed. 20%.
Yes, yes, and
yeah, because I had many patients. My colleagues were seeing the patient. It's a classical lateral medullary symptom. Medulla is perfectly normal. I used to tell them there is a new infarct. I mean, it's not the infarct is already there, but it's missed in that. If you repeat the MRI, you can see a small infarct there.
It is not that. Yes, sir. It is not the radiologist who misses the infarct, but the tissue, the biology of the patient is such that the initial MRI will not show any MRI abnormalities perceptible to our visual analysis. That is all. Another thing, the etiology is category is the king, I think, because if you are thinking of small vessel, then all these intensive statin, all these things may only have a modest benefit. Only thing that is probably going to help is the aggressive blood pressure control. Still, some of those patients who are prone to develop small vessel disease will do that in spite of all our measures. So all our secondary prevention measures may not be that robustly effective in case of a genuine small vessel stroke.
Small vessel disease. That's true.
Am I correct, sir?
Yes, sure. Absolutely correct. But given the point that the patient has hypertension, high blood pressure, untreated, you have to bring down the blood pressure.
Yes, that is probably the most effective method.
Yes. So a very small similar case, which immediately came to me. It was actually a 67-year-old male. He woke up suddenly and he noticed diplopia and ataxia, and he also was noticed to have right eye ptosis. So basically, he went to emergency. He's actually an obese gentleman and with a very high blood pressure. And the MRI was done, which was actually normal. Initially, it was actually it was reported as normal. And then,
so what do you think? It is not normal, right? Can still.
Yeah, it is clear cut. There is a right parapontine.
Yes, sir.
Midbrain.
Yeah. But he was actually being treated in another hospital, sir. So actually, it was communicated as a normal MRI there. Subsequently, he underwent a MRI orbit for the cause of this diplopia. Then he underwent a contrast MRI, and then he was actually advised for a CSF workup for this. And subsequently, he came for a second, because of the when they suggested CSF, he came for a second opinion. So I was. I got a call from the emergency that there is a gentleman with an ataxia and an ophthalmoplegia, and that MRI is normal. So immediately I rushed to the emergency. My possibility was I thought of a Miller-Fisher syndrome. Is it something like a Miller-Fisher syndrome? Because through the phone, that's what I thought. Or is it a myasthenia? This is the two possibilities which came to me. And another possibility I consider was a snake bite, because he suddenly woke up in the morning and then there is some ophthalmoparesis. So I examined him in the emergency. I went to the emergency and examined him, and so this sort of clinched me the diagnosis. So there was definitive medial restriction of right eye with abduction nystagmus, with some vertical nystagmus also on looking down, and there was also mild pass pointing on the left side with mild ataxia. So it was like a right INO when I saw that. So I was quite sure that probably there is something in that midbrain, because there is some ptosis also. So there is something in the midbrain. Probably that's what we're missing. But we could not immediately do an MRI because patient was also tired of doing multiple MRIs. So
that is the reason that you shouldn't believe the reports. You should your clinical diagnosis, and you should personally look at the MRI. Don't just buy their comments, because we never look at the reports. Most of the time, we see the MRI, we take the history, we see the MRI, and if you don't, if it's like the sinus, phenol, and all, then of course we look what's there. Because otherwise, we should specifically look for the the sites where we suspect that. In this case, anterior internuclear therapy. So you should think of a midbrain lesion. Yeah.
Yes. So subsequently, the MRI showed a very clear midbrain lesion when we repeated the MRI. So this made me sort of think about this entity called as the MRI negative stroke. So approximately 5 to 10% can be DWI negative. It is more common in posterior circulation strokes, small brainstem, as already, sir, you have discussed. So the reasons for MRI negative, it is, one is when we are imaging too early. So then it changes. It takes time for the lesions to appear. So sometimes the size is below the resolution threshold of the MRI. Then the posterior circulation is actually sort of vulnerable for this, because sometimes the lesions are small. There are susceptibility artifacts from the surrounding bone and the brainstem anatomy. And sometimes there is rapid reperfusion, and which sort of makes it difficult to find these lesions. And then there are the technical limitations like motion artifact, which all makes MRI to be negative in a case of stroke. So the typical MRI negative strokes are always INO, isolated diplopia, and the lacunar syndromes. And sometimes aphasia and mild cortical syndromes also can present. So what I learned is that the negative MRI DWI does not eliminate an acute ischemic stroke. Posterior circulation strokes are particularly prone to be mixed. Clinical examination remains paramount, and that was re-emphasized for me as a consultant. Repeat imaging may be diagnostic. Secondary prevention should be guided by overall clinical assessment, and these can avoid unnecessary referrals and patient expenses. So these are the things I wanted to present. So thank you for your patient listening.
Yeah, nice cases. Recently, I had a patient. The patient came to the ED, and they told that the patient had a fit. Patient had a fit, and they loaded with anti-epileptics, and the patient was shifted to the ICU. I was seeing some other patient. Then somebody told that one seizure has come, and patient is drowsy, irritable, restless. Then I just casually saw the patient, and I found that he has got eye movements. I just look at I mean, casually just look. There is a INO. There is a INO on the right side, and the MRI was normal. Just INO, some vague, because already he was given. All the tablets. He was drowsy. Naturally, we would think that is the drugs, multiple medications causing this. But this the INO was very the vestibular ocular reflex was grossly abnormal. Then I reviewed the MRI. There is a basilar artery was missing. Because it's a normal MRI. They thought it's a fit only. So there's a normal MRI. There is no diffusion restriction anywhere, and there is no infarct also. And the MRI, they didn't check carefully for any vascular events and something like that. But I checked zoomed and found that there is a mid-basilar segment is missing. There's no flow void in the mid-basilar area. And they took the patient immediately to the cath lab. There is a basilar artery occlusion, and we removed, and he was back to life. So always the clinical diagnosis is the one. Don't just buy the diagnosis of seizure or some other thing before embarking the treatment.
Thank you, sir. That was...
So all the cases are really good and fantastic lesson, nicely worked up. And thanks, Jisa and Karthik.
Thank you, sir. It was an honor to present. Thank you.
Srijit.
Thank you, sir. Thank you, sir. Thank you. It is an opportunity to learn from you and also Karthik and Jisa. It is both the cases were wonderful, and discussion was also lively. And thank you for the opportunity, and also to the organizers for including me in the moderator panel. Thank you.
Us. That's more because everyone is good. Yeah, because I also learned a lot from you.
Yes, sir. So I would like to thank all the faculty members, our course director, our moderator, and both the speakers. I think for our entire audience as well, we had an audience of around 50 plus HCPs who joined us online, and I'm sure they all have, taken something and learned something new. Because stroke being such a time sensitive and such an important therapy, that there is no one right treatment. The approach is very different, and the approach is different for each case. So I think it was a great platform for all of us to learn And I would really like to thank all of you for your valuable time, especially on a weekend. And we look forward to have your participations even in the coming sessions going forward. Thank you so much to every one of you for
Thank you.
joining today.
Thank you. And
Thank
Thank you.
good night, Srijit.
Good night. Good night. Good night, sir.
Thank you, sir. Good
Thank
night,
you
sir.
so much.
Good night.
Thank you.
Thank you. Good night, sir. Thank you.
Can we sign?